Welcome, listeners, to our third episode of our second season. I'm Rohit Sehgal, Chief Strategist here at the Voices Project, based out of Singapore and covering most of Asia. We're a group of like-minded health editors, researchers, and writers who spent a career in trying to track the evolution of healthcare in parts of the developing world, especially Asia Pacific. So essentially, what you're hearing is a neutral, independent, not-for-profit platform that aims to produce deeper insights and knowledge on public health issues in Asia Pacific. And what we try and do is to root that in local circumstances, experiences, and of course, the divergences that we live through every day here. And you've heard me say this before, but only by empowering voices and the issues that matter, we seek to accelerate many of the key healthcare priorities facing our region today. So for those listeners who are tuning in for the first time and want to know a little bit more about what this season particularly is focusing on, the objective for this season is to try to lay the foundations for a regional understanding and framework of the role of technology in life sciences. And by doing so, what we aim to develop are region-specific consensus that can be leveraged by policymakers, healthcare professionals, actors in the private sector to better facilitate the development and rollout of medtech policy in Asia. And it's by taking a continental rather than an isolated, localized approach that we believe that this will also help serve a lot of UN agency goals, particularly SDG 17. For those listeners, that's the Sustainable Development Goal, which focuses on the paramount importance of technology in driving universal health coverage and many of the non-communicable disease factors facing Asia and the Pacific today. Would certainly suggest a good read of that, which you can find on the WHO platform. And by developing broader collaboration amongst policymakers and agenda setters, we hope to complement and build upon existing initiatives and just get us there faster. Well, with that preamble, let me not waste any more time because we have such an exciting episode today. I'm joined by two evangelists of health, technology, and the human condition. I'm just so delighted to have the ever insightful Rahul Malhotra, the Global Head of Brand Strategy and Brand Stewardship at Shell, and the irrepressible Dr. Kiran Priyadarshini, Worldwide Lead for Health and Life Sciences, JPAC at Microsoft. Now, before I ask them to introduce themselves and give a little bit about their backgrounds, the reason I wanted Rahul and Karen to help guide us through this particular episode is because it's one that needs more light to be shown on. And it's really the question that, are we at that era of consumerized health digital literacy? We talked about this health and digital literacy gap in some of our earlier episodes, the fact that it's now being paramount in driving future health preventions. So how can leading experts in consumer and B2B solutions provide a more interoperable North Star? So with that little bit of a context and background, Rahul, tell us a bit about yourself.
So good morning, I'm Rahul. I'm just a brand guy, but I worked with both Procter & Gamble as their Asia Head of Healthcare Marketing a while ago, and now in energy. And one of my personal passions and why I'm talking to you guys today is I hope to inspire more and more company, organizations, private corporations to make a greater effort to partner towards the pursuit of SDGs, in this case, healthcare. And I genuinely believe that all of the skills, resources, and talent that private corporations can bring can provide mutual benefits to both our societies, as well as to their shareholders and reputation. So more to talk about that later.
Thanks, Rahul. And Kiran, for the listeners who've not heard you on our previous episodes, would you like to give us a background to you as well?
Yeah, sure. Thanks, Rohit. So hi, everybody. I'm Kiran Priyadarshini. I'm the regional business lead for JPAC for healthcare and life sciences at Microsoft. And at Microsoft, my role is basically to work with our health industry partners, and we strive to achieve the goal of better health globally. offering people and the care providers, our patients and other care organizations, a people first solutions, so that, you know, all these organizations and caregivers feel empowered through technology.
Thanks for that. Now, with that, many of our listeners and a lot of people that we've been sort of interacting with have asked us that how can principles of consumer or B2B engagement strategies provide the necessary innovative solutions to particularly some of those pressing issues that face our health systems today? Much has been said that health policy and technology policies tend not to work in the best of sync. And what can we learn from that? What about the awareness factors? What about screening, adherence, compliance? I'm going to ask our guest today to try and apply some sort of a real world scenario, because a lot of this can sit in the ether and it can sound very much like it's academic. But how has technology reshaped health consumerism? For example, digital literacy being as important as health literacy. Raul, why don't we start with you on that one?
I think technology has evolved over the years in terms of the kinds of tools that are available. If you look to the very beginning, the advent of terrestrial television in the emerging markets was technology in a way, right? Because that's what led to education around things like family planning or get your polio vaccine or, you know, stuff like that. And over the years, I mean, it has evolved now to social media, digital, and now cloud, AI, and other things. But at the heart of it, healthcare is about the human being. And all of these tools that are now available have to be leveraged for the sake of helping those human beings drive hopefully better preventative behavior. And if not, at least to get access to solutions which are digitally enabled. Even a doctor who's available on video call or a midwife who's available on a text message in Nepal, you know. So that's my perspective on how technology can really help deliver better outcomes.
Kiran, health consumerism, is that something that you're an advocate of? Is that something you're seeing developing?
Oh, absolutely. Absolutely, Rohit. And my answer is a big yes when it comes to technology. So let me, if you don't mind, let me give you a slightly long-winded answer. So, you know, patient demands, they were shaped really with the COVID-19 pandemic, and they actually pushed hospital systems into like a digital age. As you know, we've been talking, and healthcare has normally been a laggard, but in March 2020, I would say the world almost changed overnight. And now a consumer-centric model for healthcare is actually guiding the healthcare system to understand the patients, to be able to anticipate and meet customer needs while still offering transparency, something that was not there or was in, in limited fashion. Now, when you talk of health consumerism, what we have seen is that, passive patients have become empowered consumers, just like in any other industry, and their search for, greater value, better cost, better quality of service, a timely and convenient care, being able to have transparency of information. At the same time, having a very positive patient experience has become very, very important, both with their caregivers, with patients themselves, with physicians. That partnership has become very, very important. And so what we see now is that consumers or customers, or you may call them patients, they want access. So people appreciate the access and the convenience that digital health can actually give them anytime. And that's where I think technology plays a big role. And if you look at the changes that have come about in health consumerism, they're basically, I would say, 4 buckets, right? One is, of course, the communication with the physician. And, earlier it was always like the doctor says and the patient does. But now I would say it's more like a partnership with all the information that's available. Patients can also kind of discuss options. The other one is patient buy-in and compliance with treatment recommendations, because when it's a partnership kind of a model, the patient and the caregiver is involved. So adherence to a medication, adherence to a care plan is much better, because it's no longer like a top down, but it's more like a collaborative approach, right? And then of course, the whole thing around, I think I've been sharing earlier as well, is around patient lifestyle, wellness awareness, and not only just cure, but preventive and healthy activities and behavioral change. All that comes in with health consumerism aided by digital health, or you can say technology. And I think for our listeners on the call, I would say that, convenience has become the new currency. And for health systems and for providers, to have a kind of a competitive edge in the minds of consumers and patients, convenience is a primary requisite. And that's what, technology can offer.
It's interesting that you both sort of reflected on these parameters, because you think about how the consumption of digital is now also evolving, and I think as you said, is moving from this passive to an active. Is that because while health literacy is still this sort of like, how do I handle my health, what is this all about, what does this diagnosis mean, the somewhat more familiar aspect of digital knowledge, or being able to connect through visualization mediums or multi-channels or multi-surface, is that helping to bridge this divide as well, do you think?
I fully agree. I think in the past, if you look, even the most educated people, when told a complicated diagnosis by the doctor, didn't really comprehend what it was. They relied on somebody else in the family who may have got it. Today, you can not only Google the symptoms, you can see YouTube videos about what it is and how it's fixed, what the surgery might look like. You can also join Facebook communities of people who faced this worldwide. So, for example, you can feel part of a community of people healing together or dealing with this together, whether it's cancer or something else. So I think those are just some examples of how suddenly the patient experience and comfort with a certain diagnosis or situation has been enabled by technology. I would argue even doctors.
Well,
Doctors feel more confident feeling part of a community if they are connected through digital, if they're trying new technologies and things like that.
I was going to say that in terms of what Kiran said earlier, that what part of what technology is enabling is this age-old conundrum of the doctor-patient divide. And, I think that divide was getting really scary, particularly when you're talking about less informed or educated communities that don't really understand what condition this is and are looking for a cure rather than realizing it's chronic. It has actually brought doctors and patients in some form closer adherence and compliance factors, simply because now there's a mechanism or a methodology. Karen, is that, I think, what your point was in terms of you were describing the various pillars that are enabling this more closer outcome?
I would say because, healthcare is so broad, Rohit, and then digital health is another layer that you're meshing on top. So yeah, those I would say are the four areas where you do see, health consumerism. What I would say, what we call it also as retail health in a way, and, finance also coming in, banks are also coming in. So if you remember our discussion earlier, we're talking like of an ecosystem now, right? So because of health consumerism, you have a lot of retail technologies that are being used in your shops and shelves, coming into healthcare. And I think Rahul, given your P&G background, that is something that you might want to comment on. And same thing with hospitals are now kind of, they have pharmacies, right? Those pharmacies are turning into retail stores. Now that all is exciting, because then what you're looking at is your consumer behavior, which product is being bought by whom. I'll give an interesting example that I found very exciting. In Korea, I wouldn't be able to give the name, but the way they are establishing malls, and in Singapore, Rahul, ours is a mall country, right? Imagine in Korea, for example, we had this very interesting discussion where malls are going to be set up based on the profile of population living around it. So if you have a lot of elderly care, if you have a lot of diabetic or chronic disease patients, then the mall is going to house products which kind of cater to that group. And I think that's what we do in retail, right? I mean, depending on which products fly off the shelves, you want to keep it in the front. So I find that very exciting. And also to add to what Rahul said, in information is I would say, the low-hanging fruit. So as Rahul rightly said, Facebook, even just Googling onto, information. I don't know about you, but many times what the doctors write in a report, it's all mumbo jumbo, it's absolutely not clear. What does that word even mean? And then you kind of go and search and try to understand. So that's where the patient involvement comes in. And as Rahul mentioned, for cancer, it's very important because, cancer, life is shortened, and you're really scrambling for information. There could be rare forms of cancer. And this is where we've seen, because I work in life sciences as well, we've seen patient support groups coming up in a big way. Pharmaceutical companies actually supporting these, they cannot reach out to the patients directly, but this is a very nice way, a digital way of putting information out there so that your patients can actually get support. They can send in their queries in a very anonymized, you don't know who that ID is. So that is one thing. And then you mentioned doctor connection. I think even doctors, now it's all a learning age. It's no longer like, I've become a doctor and I'm done. No, no, no. Technology is advancing so much that even doctors need to learn. And as you were pointing out earlier, doctors can stay connected with, let's say, the experts. I know we do have these conferences, which kind of bring everybody together and you learn, but now it's much more faster in the digital age, right? I can reach out to any other doctor, have a quick conversation, see what the other doctors are working on. And one of the technology I think I mentioned earlier, and Rahul, you should try this as well. You should come over to our office, is HoloLens, right? It's on mixed reality where, a doctor can be sitting anywhere on planet Earth. We've yet not tried. In fact, I had a very interesting conversation yesterday with one of the doctors at NUHS that they're talking to astronauts. So health of astronauts, how do you kind of, sitting here on planet Earth, how do you talk to them? So those are some very interesting technologies that are actually kind of, making borders disappear. So yes, the answer is a big yes. Consumerism is just another piece to the puzzle that's pushing digital health to its very extreme.
Absolutely. Now, let's go one step deeper into this and maybe try and take a leaf out of the consumer health strategy playbook. Now, we've talked a lot about doctors, and I think most listeners would assume or visualize, folks in white coats, sitting very formally there, making decisions on your behalf, and it's a very sort of a one-way kind of a dialogue. But let's talk about the reality of the situation. Most of this region relies a lot on rural medical practitioners, midwives. Indonesia is held up as one of the case studies in terms of the IBU network, the way that a loose confederation of women particularly came together and created one of the world's largest support groups, right from maternal, newborn, and lifelong. Now that's a large population. We're talking hundreds of millions. India, most of Southeast Asia is being serviced by a loose affiliate of primary healthcare providers. Now, in the old days, I think Rahul will remember this from his PNG, there used to be somewhat derogatory terms, quacks, they don't know what they're doing, RMPs, what do they say, how are they even, legitimized and all of that stuff. But things have evolved, the ASHA networks that we hear coming out of India and the way that it's come together. Now, talk us through, Rahul, I guess, the evolution, because you, I'm sure, have a lot of war stories to tell about how rural marketing from a consumer lens has, in a way, taught us that we can actually support, guide, mentor, and now with technology, almost be in the palm of their hands, ensuring the right information reaches the right people. But talk to us a bit about your times at a consumer health perspective and what's changed.
Sure. I think the starting point is if anybody is still doubtful of the role of private corporations in lending their experience, expertise over centuries and skills, I think the role of private corporations, in my view, is they have the money, they have the talent, they are trusted more than some of the local government in many cases. The expectations from investors, communities, staff is for them to make a difference. They have the tech. And here's an interesting one, their reach, which is relevant to what I'm about to dive deep into. The physical reach of some of these companies is very, very high. I mean, if you think about FMCGs in countries like Indonesia, India, China, the number of people that they touch through their indirect and direct channels is in the millions, tens of millions, hundreds of millions. And each of those people in the sphere of influence can impact another X thousand people. the digital reach. Nike on Instagram had more followers than Donald Trump had on Twitter. So a single post from Nike, talking about D&I, for example, would make impressions equaling what Mr. Trump would have said on Twitter. So the power of corporations to make a difference is significant. So now let's dive deep into this. There's one thing that companies have, which I think healthcare providers, governments, and nonprofits can take from, which is the skills in what I call habit change, or skills in reaching and influencing at the micro level. In developed markets in recent years, we've seen those skills come up with the advent of things like cafes, and that's a habit change. Going to Starbucks to buy something is a habit change. It's been cultivated and curated by expert marketers in Starbucks and elsewhere, right? Or the use of apps like Strava and getting people addicted to Apple Watch and all sorts of tracking apps. That's marketing. It's not enabled only by technology. It's by supermarketers understanding consumer behavior. How do you force that habit change to go and bike and switch on the Strava app? But now let's dive into developing markets. Now, in developing markets, the kind of stuff that I've done in the past and what continues to be done is what is often called POME, or point of market entry, right? Point of market entry has been done over the decades on so many things, switching people from neem toothbrushes to a plastic toothbrush, which in retrospect is bad. You should go back to wood. Switching people from soap usage on the head to shampoo usage via the advent of sachets, which is also plastic, which also has to be done. So we need new solutions today. Cloth conversion. So I was the global brand manager for emerging markets and Pampers, and my entire focus was, traveling South America, Africa, and Asia on what are the habits of moms who use cloth on their babies for a diaper, and how do I convert them into that single overnight diaper, and then over time expand that to maybe one in the daytime, maybe two in the daytime, and so on and so forth. And so that cloth conversion was such a sophisticated skill that we had. We knew exactly which market was ready at what point to develop. How do you convert millions en masse? How do you use maternal and nurse networks and so on to sort of influence that? How do you work with doctors and hospitals to give that sample when the baby is born with a lot of proper information on how to look after the baby, and how that leaves a lasting psychological impact in the mom, because she then never changes the brand, because she's very scared that, oh, the new brand, I don't know who they are, what it's all about. I personally used to lead millions of contacts of little girls in the 12 to 14-year-old age group in schools, where you go and educate them on the advent of puberty and give them samples of femcare products and teach them what it's all about, because parents don't teach them in emerging markets these things. So many examples, and essentially it's about the reach, which also includes partnerships. So we partnered when I was in healthcare with these Anganwadi workers who would be going to the villages anyway. So how do you incentivize them to sort of get some extra revenue, but also distribute your products and teach people about the best way to manage their flu symptoms and so on with some products and so on. So there are various ways, but I think it's been boiled down to a fine art in these companies over the decades, 50, 100 years that they've been doing it. And one of the things that I'm very impressed by was something my competitor did, which was Unilever in Africa with the partnership with the WHO. This was also 20 years ago, where they actually, and they continued it for 10 plus 20 years. I'm not sure if it's still continuing, but hand washing is linked to Lifebuoy from a commercial end. Hand washing is linked to diarrhea from a health end. The local governments, the WHO and Unilever partnered over many millions of people in Africa to reach these villages. They had contests, education stuff around, the more number of wrappers we get from your village for Lifebuoy, that means that more people are using their washing their hands, which means that I'm selling more products, so you'll get an award, such as I'll build a school in your village. and so on. Now, obviously, that also meant that the diarrhea incident came down in those villages as more and more habit change happened. But that outreach, spending that money to go there, educate people together with the WHO and the local government, was an idea initiated by a commercial interest, but with a very strong SDG link back when SDGs weren't even talked about. So I think these are just some, war stories that I can talk about on and on, but I think there is a huge amount of learning as well as partnership and collaboration that can come if the sort of that intersection matches between what the health goal is and what the commercial goals are.
Come on, Kiran, you're going to have a lot to say on what Rahul just said. So I'll let you say what you need to.
Yeah, I would say that awesome stories, and I'm so glad you talked about the addiction to the eye wash as well. So the stories are amazing that you shared. While you were speaking, I was just jotting down as well. So I would say the story has two parts. The one part is where absolutely spot on. I think I love companies like P&G and Unilever, the kind of research that they do and the stories that you shared about at P&G, we used to do it as case studies at business school, So, and I think the part I love the most, being a researcher myself, is the kind of market research you do. The patient diaries, the patient interviews and surveys, and you observe them. So awesome! I just love that part. So that's one part. So that's where I would say, amazing work. But how do you make that perpetual, right? How do you? So you have, let's say, X company working very closely, you build up a few villages, but how do you make that perpetual so that when the company leaves, it still goes on? And how do you integrate them with the rest of the national fabric, right? So let me give you an example. So you, I think Rohit, you were speaking, and Rahul, of Angawadi workers and Asha workers. So one of the things that, and I'll give you two examples around this, right? So we work with a partner called Reach 52. Microsoft per se does not have products, but we empower our partners and we give them the technology. So what Reach 52 has done is exactly what you said, Rahul. It's like, go to the villages, and the basic problem in villages is the lack of doctors, lack of information. So one area which is very passionate for me is around child mortality, especially, female infanticide as well, where you kind of, most women die during childbirth simply because of the midwives were not skilled. So this is where what Reach 52 does is that they go there and they train the trainer. So what they do is they train the first level, and then these people, these are the Asha workers, they then are skilled, and then they go and train the next level. So the people who are actually there in every village. So it kind of becomes like a multi-level marketing. You have the top trained, and then the next level and the next level. Now, one might wonder, what's the incentive? Why should I even be trained? So A, it empowers the Asha workers. They know what they're talking about. So it's more like a personal growth. B, they see that they are making a difference. So in terms of number of, deaths of babies, of mothers is going down. At the same time, of course, there will be situations where, it's beyond them. And that's where at the village level, you can set up a simple telemed, just an iPad, where you can do a quick telemed with a doctor who's sitting in an urban hospital, and with the camera, you can actually see what's happening and guide the Asha worker. So for the Asha worker, it's like a level higher. They are like learning more as they go, and they're empowering. That is one. And so what happens is this village becomes self-sustaining when it comes to healthcare, because they learn, they're able to kind of, share it. And of course, best practices are shared. So all these doctors, the telemed doctors, we conduct with the help of pharma, we conduct regular training sessions. We don't get into at the village level, but we get in at the doctor level. So the doctor trains the Asha workers train the next level. And this keeps happening. And the beautiful part is that you see they're slowly integrating into the ecosystem. And how is that? Now, these doctors who are being trained, this is where the commercial angle also comes in. They are sponsored, if I can say, or they are supported by pharmaceutical companies who want them to be aware, A, of diseases, B, of solutions that are being offered in the market. So everybody has a skin in the game there. The other thing is what Reach 52 does beautifully is that They use technology to integrate all this information into a neat little app that the ASHA worker can use the camera to scan, let's say somebody has a wound or something, scan the picture, as well as a simple, if I can call it an EMR system, not exactly a medical system, but a system to kind of, have all your medical conditions, the medication that have been given. So that starts building into a village EMR. Now, the beautiful part of this, how do you get into the national fabric? Now, as you know, India is rolling out, and I'll come to the Indonesia as well. India is rolling out, and so is Indonesia, a national digital health platform. Now, because it's cloud-based, using a simple API, you can plug into the main backbone. So these villagers, these ASHA workers who were earlier probably keeping the records on paper are now into the grid. So which means that if this villager goes to the city to do his work and has a problem, he can just log on into with using a unique ID, which is very important, and see what has been the case history. Now that's where I would say technology comes in, where all the good work that we are doing with public-private partnership helps to bridge that into an ecosystem. So boundaries, geographical boundaries become immaterial. And there's a third phase where the patient starts carrying that data. I mean, we're not there yet, but the patient would have all their data into a simple health app. And so they're able to show it to whichever provider they go to. So I think it's a beautiful way in which, digital health can kind of make that permanent. And I think, Rahul, we've seen this with the COVID vaccination, right? When you want to fly out of Singapore or into Singapore, you just need to flash your little app. So extend that, let's say, to a rural setting. So I think I love the fact that technology, in a very simple way, can actually bind that fabric. And the other example I wanted to share was of Indonesia, right? This whole public-private thing. Even non-healthcare private players are coming in, right? So, Indonesia has 7,000 islands. So literally during the COVID vaccination period, they had to put their vaccines in a cold temperature across in boats and take them all over the place. But the confusion was that people didn't know the vaccines were there, supply-demand mismatch. So this is where, like in Indonesia, we're working, and it's, I think even in Singapore with Singtel, in Malaysia with Telecom, Malaysia with their own telco, and in Indonesia with Telkom, they're saying, hey, how can we help technology reach last mile? Because, we can provide you that connectivity that's so important. So you might have like a simple 3G, 4G phone. How can we kind of use that to get technology to reach the ends of the earth? And, in India, we have eSanjeevani 1.0. We are working for eSanjeevani 2.0, where you're saying people can have different types of phones, smartphone, basic dial phone. But how do we partner with telcos to be able to give? Because everybody now has a phone. I mean, that's going to be your point of interaction in healthcare as well. So I love the fact, and that's what I think this whole ecosystem play that Rahul, you mentioned, where you have companies that are in healthcare, companies that are not in healthcare, coming together and contributing their little part in a very, how to say, win-win situation, but at the same time, betterment of health. Because, you might wonder, is somebody losing out? The answer is no. You're just making that healthcare pie bigger. Earlier, it was probably only for the urban folks, urban hospitals, but now the big chunk in India, like 60% is rural still. So you're getting all those folk. So the pie is becoming bigger. Everybody is going to make more money, and health is going to be better. People are going to live longer. It's a very nice, I would say, situation to get into.
Yeah, and not just technology getting better, but technology getting cheaper. Because one of the things that I've been hearing a lot about is that, particularly from a lot of public hospitals in the region, is this last mile, Karen, as you reflected on. And I think, Rahul, you've talked about it in your experiences on how do you get village-wise sort of collaboration. It's the physicality of being able to follow up, with the lack of any real available patient record. So in certain, and this is part of the dichotomy of this region, we have regions which are almost perfectly set up, where by the tap of a phone or a tap of a device, we're suddenly connected into the grid. But many times, a lot of what hospitals, doctors, frontline workers have was at best a mobile number scribbled on a piece of paper. Now, there's remote parts, as I think, Karen, you've rightly pointed out, 7,000 islands. I mean, that's just Indonesia. You go to the rest of Southeast Asia, far-flung areas. We're trying to encourage more people to come for earlier diagnosis, earlier awareness, have a better understanding of how they can avoid that slippery slope. But then how does somebody who's just been diagnosed with diabetes or just had a mammogram screening report, for instance, how, the actual staying in touch, the EMR's factor, how is there still a gap that we need to be filling, or is this now, as you were saying earlier, it's now reaching a point of equitable balance?
I can share, just as an observer and passionate person, I think the first and foremost, we need to catch the low-hanging fruit. I'm fully aware of the thousands of islands in the Philippines and in Indonesia and elsewhere. I think the point is, first, can we connect them through virtual, networks? So, for example, in all of these villages, can you have people connect centrally to doctors on video, at least for normal GP or specialist consults on pediatric issues or maternal health, or, and so on. I think first and foremost, we need to enable that. Secondly, we need to build those communities virtually. So suppose you have a village of 10 people, suppose there's an alcoholic in there. He has nobody to talk to. There's no AA there, right? Or if there's somebody who's a heavy tobacco user. Now, if there is a way to link this community of 50 villages and find 50 alcoholics who can talk to each other in their native language, all within the same province of Indonesia or Thailand, that's a community that's helping drive preventive healthcare where they can talk with maybe a facilitator. So I think that's the short term benefit that we should all strive for. And that's where a lot of investment should be made, because that's going to help immediately. Long term, the physical presence of doctors either going to these villages or these villagers being enabled to come to central locations is going to be critical, and it'll be critical for some needs. And again, I would say private sector infrastructure goes to these places to deliver your Coca-Cola. Private sector initiatives are done to, go and reach and sell their stuff there to shops. And even if they come once in 3 months, that's still a truck going into that village or a ferry or whatever, right? So why not partner with them and say, look, you have logistics. Can we share the logistics cost to either transport the doctor to the village or vice versa? And I think that's where the role of technology from companies like Karen and Gang will come in, because that organization, that sophistication at the grassroots level has not been thought of. And I think it's just an absence of collaboration.
Karen, collaboration, is that a factor to put into one of the issues you mentioned earlier?
Yeah, absolutely, Rohit. But I would probably be in a different angle to what Rahul said, is that I don't think we can physically send the doctor anymore, because the doctors are very few. I think every market I speak with, the first thing that comes is a shortage of personnel. And I think COVID has really kind of drilled home the point that we are never going to make it, because people are going to get older, sicker, and we're always going to have this shortage. And rural makes it even worse, because then you're taking away resources from urban and trying to push it into rural. Urban is high value, rural may be low value. Nobody's going to go unless it's a punishment to the rural areas, or unless you're really learning on the job, right? So the way I look at it is slightly different, and as agree totally with Rahul said. But I feel that the low-hanging fruit are the doctors. And I think the way one should do it is, in all the rural areas, be able to get care or access to care through telemed. You just need an iPad or a phone where you're able to kind of provide basic care first. I mean, forget fever, somebody has a flu. I mean, those kind of basic care we need to start with, right? Because that itself is an economic expansion. You're going to get revenue from that, and doctors would be incentivized to do that. And what we've seen with the e-Sanjeevani example as well, doctors do an 8-hour shift, but they can take a few calls, 2-3 hours. Even in Singapore, we see that once they finish, they are able to do with other about 2 to 3 hours. So it kind of brings in more revenue, more use of an already scarce resource, right? That's what I feel. One second, when you do all this telemed, one thing that healthcare has always forgotten is to collect that data. collect that data in a way that's reusable, interoperable, because I can see millions of patients, but after that, I have no clue. It's only the doctor getting skilled, but what do I do to be able to learn from those 1 million patients, right? So data has to be definitely collected in a format that is easily usable, irrespective of whether you want to put it into a national grid or you want to do some analysis out of that. So that's very important, right? Because we all know if you want to fix something, you need to be able to measure it. That I think is point number 2. Point number 3, I think in rural areas, instead of targeting everybody, target the mothers. I've seen that some of our partners who do it really well. Because when you work with a mother, you work with a family. You know, they have their kids that they're very focused on, and then they would obviously bring in the others as well around them. They're good word of mouth harbingers. So they, you know, once they have something good, they're going to go yak, 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 you know, all around. So I think that's where you start with mothers' health. So that's one thing that's often neglected, women's health, then their children, which are the very important for them, vaccination. I think build from there. Once you have the women, then you bring in the whole family, then the neighbors, everybody comes in. So build small, but build consistent, collect the data so you're able to do analytics. And I think to your question, Rohit, I firmly believe that there are 2 things. One, AI and ML models. You see, I could have, like, for example, you said diabetic, they could have cancer. All these are preventable, right? Like cancer is preventable. So we do have, you know, villages going through screenings in the Philippines and so on. People do screening. So if those images could just be sent through your normal internet or your whatever Wi-Fi you have at the rural areas to the city hospital, where somebody runs these images quickly through an AI model, result can come back within like 7 to 8 minutes. And all it does is not to replace the doctor, but to say, hey, these are the anomalies that we see, might want to do a deep dive. So you're preventing the problem from becoming really worse, right? You're able to capture cancer much earlier in, let's say, stage 1. So you see Philippines breast cancer, Singapore breast cancer, lung cancer is on the rise. So let's catch it young or earlier, if I can say that. That I think is super important. Same thing with diabetes. If we were capturing all that data, you can easily see that, hey, this guy is a high risk for diabetes. So let's intervene earlier. And, you know, the whole example I gave earlier, where you're also equipping the doctor to talk to the patient, you know, this is the data that is being seen, and based on a profiling, seems like you're high risk for diabetes, high risk for cardiac, so let's have some active intervention. And that's where I think this whole consumerism and smart wearables come in. I think an area where smart wearables, I push for them, is because they give you data in a very continuous fashion. Like you could have heart rate measurement, blood pressure measurement 2 to 3 times a day, right? And so that's where you're looking at behavioral data as well as how many steps does this individual walk? Is he or she an active person? Is she a more sedentary person? So I think those kind of behavioral data now, as I see from a healthcare perspective, is as important as your medical records. So how can, and since we're collecting the data in a very smart way, we should be able to analyze that. It's just like how Rahul and PNG, you know, we get all these, do you like this? Do you like that? How would you behave that? And you go back and analyze that data, and becomes amazing market intervention. I think we should do the same in healthcare. You know, how can I profile the human being as a product and say, what are some of the risk factors? What are some of the interventions, and when should we do that? I think that's why if we start from the rural side as well, it's a push into the urban, right? It's like a, how to say, a symbiotic relationship, urban to rural, rural to urban, the linkage becomes stronger. So I think smart wearables is a cheap, effective way of getting that started.
If I may jump in, I think we have a situation where tens of millions are being spent on video game development. No investment is being made in a easy way to, for example, sit in a village and have something on your heart and have that heartbeat transmitted to a doctor far away for them to see your lungs. No investment is being made on an easy blood testing device, which is then distributed to every household like COVID. And then, you know, like an ART test, you test your blood, you put it in the app, and through machine learning and all of that, it automatically sort of learns what are the issues with your blood. The healthcare practitioner has access to it. Already, I believe some people have launched something to do an eye test using an app. So what are the things that the physical doctor would normally do, right? They would use a stethoscope, they would do a blood test, they would listen to the voice, the rasping, I don't know, right? So stuff like that. All of that can be technology enabled. And I think that's the innovation that's missing. Whether it's wearables or non-wearables, if we can make that innovation financially feasible for these amazing that same person who designed the Uber app or the Strava app can be used to design a user-centric app to test your blood or to test your diabetes or whatever, because they know how to navigate that digital experience, right? And I think that incentive is missing, and that incentive will come from that private-public partnership when that meeting of minds happens, and common goals, common agenda, common modeling can be done.
If I can just respond, Rohit, to that. So Rahul, you're spot on. So, if the camel doesn't come to the Arab goes to the camel. So
yeah,
you're absolutely right. So when it comes to investment, I think what you suggested would be a very good route where private players can actually pick up. These technologies already exist. I work with so many startups. It's just that there is nobody to give them that scale. And I think this is where what you suggested in terms of, private players like P&G or Shell, they always like adopt villages. And I think this is where they can work with startups and be able to, give those devices on a trial basis. And the interesting good part is that technology is already leapfrog. We even have whole body scan, right? So you can just get your whole body scan. It'll tell you where all the anomalies and tumors and all this are. But the good thing about this is that, as you rightly talked about games, and so what came to my mind is because games is something that is addictive, you just cannot wean people away. This high amount of investment. So what we finally did, we found startups that actually are bringing games into healthcare. So we call it as gamification of healthcare, especially for rehab, right? And this becomes very interesting even at the village level, where let's say somebody's had a surgery and now this person has to kind of recoup or recover. And you can use simple games where, it could be activities that you do at home, like for women, ironing, washing vessels. But again, through this gamification of these exercises, they are measured. So the doctor, instead of saying, oh, lift your hand, I want to see how much it can move, he or she, even before the patient comes in, can look at data. What is the required, let's say, height that the hand needs to be moved to versus what has the patient done? So using that measurable data, the doctor already has a sense of, do I need to extend rehab? Is the patient fully recovered or not? So I think that is one good thing which has recently begun, where gamification, right from elderly who can still, play games to the middle age, to the younger age, that is something that is also catching on.
Yeah, you're so right. And in fact, you've touched upon an upcoming season where we're going to talk about gamification and mental health and neurological degenerative diseases, and how already there's so much in terms of planning, diagnosis, and screening that's coming into play there. Now, one of the things that healthcare has always been said that we don't do enough of, and I think you've both been touching upon that right now, is that we don't adopt more patient segmentation when it comes to health assessment tools or health technology tools, HTAs. Now that's a huge, huge drawback. And you would almost ask yourself, that's a massive opportunity missed. Now, psychometric behaviors, we've always said, can be equally, if not more compelling as clinical findings. And I think Kiran and Rahul, you've both been talking about the non-clinical value as well as the clinical value in coming out with a better, almost a 360 view of that patient profile. Now, it'll be wonderful for our listeners, I guess, in a summarized way, to have some takeaways on what would you think are some useful methodologies? How would we try and segment perhaps those who are averse to screening for financial reasons, maybe, versus religious, maybe just don't even understand the disease? Are there areas in consumer marketing, perhaps, that are taking this already into place? And perhaps we can take a leaf out of that. Rahul, would you have any thoughts to that?
Yeah, I think absolutely. If we start with why segmentation is useful, it allows you to focus your resources and your offer on the geographies or the consumers and humans who are most likely to buy your product, and that segment is large enough to meet your market share goals. you can take the same principle and say, I'm in a village in Indonesia, or I'm in all of Indonesia, and I'm trying to segment a group of people who are most likely to reduce their smoking behavior, right? Now you would start, and segmentation would be demographic, age, gender, and so on, but it would be also behavioral. So people who smoke more than X times a day, or people who smoke a certain type of, unfiltered tobacco, or, people who do X and Y. Uh, uh, and then there would be psychometrics, people with a certain psychological profile or a propensity to listen to you. And so the way it would be approached in a private sector is, first and foremost, you would go and speak either via focus groups or one-on-ones to at least 50, 100 people, right? You would go to these geographies, sit with the environment and understand. Then you would come out with hypotheses on what are these segments that are coming out from a psychometric point of view. You would find, and you would give them fancy names, like health seekers and this and that, or sort of apathetic, and so on. And you would give those names. And then the next thing a private sector player would do is quantify the size of each of these segments, where they would do a quant survey asking people, how often do you do this, or how much do you agree with this? And that survey of X thousand people, you would then get a size of each of these segments, right? Obviously, there will be overlap, but at least there would be some distinct idea. Now, suppose you find that in Indonesia, there are these 50 million people you found who meet your criteria of the health seekers, willing to stop smoking. Then this quantitative study will also give you an idea of which parts of the country do they live in, what media do they consume, what are their favorite TV channels, TV shows, what are the other habits where we can reach them. So a private player would collect all this information in order to then target them using communication and other incentives to get them to change behavior. So in this case, instead of changing behavior to shift to a different toothpaste brand, it would be changing behavior to say, have one less cigarette a day for 1 week and two less cigarettes a day for the second 2 weeks, and you get an incentive after that, or something like that. So there are 100 ways to do this, but that's how segmentation could practically then be taken forward.
Yeah, Kiran, I think you've been touching upon this in your earlier points, but something around health assessment, predictability. You mentioned AI and machine learning playing a role. Is that something that features here as well?
So absolutely agree with what Rahul said, and I think we got to learn a lot from marketing companies and retail companies, because they segment, consumers beautifully, and that's how probably they're so successful. But interestingly, what we have seen in healthcare, and I have partners like Cusin that I would like to mention, who are like groundbreakers in this area, where data scientists have seen that you can profile people. The lazy way to do it is probably demographic, gender, age, blah, blah, blah. That is an old fashioned, I would say. The better way to do it is with, as what Rahul said, with SDOH data, which is social, demographic, economic, and health data, right? What that means is the ecosystem around the individual is not only your finance, so you have everything in, right? Like, and healthcare data is, you have all types of data. You have financial, you have medical, you have social, demographic. We also key in if you're participating, like what Rahul said, in surveys and things like that, you have all that data. But what we're looking at is only the medical data, which is why we're having an incomplete picture and people are getting into the sick bucket. What we need to do is, using interoperability, use first thing, all types of data. So let me give you an example. If a hospital is looking at estimating patient flow week on week, the simpler way to do it is, okay, just look at the past year's data. In the month of June, how many patients did I see? Okay, estimate. No. That is not going to work anymore. What we have seen interesting AI models build on is patient flow data, seasonality. Is it a flu season? What are the weather patterns? Looking at major events that are happening in that country. and a lot of other factors. So put all that together and be able to predict. So your accuracy level really goes up because you're looking at all factors which influence the dependent variable, right? So similarly with health, if you're able to look at the data around that ecosystem of the individual, so my leisure activity, financial, my health, my social, community, if you can get all that data together and then be able to segment, it's super powerful. Now that's part one. Part two, once I have all the segmentation done, now what, right? There are end goals to be achieved, right? I want somebody who is pre-diabetic to remain pre-diabetic, not become fully diabetic. Somebody who is high risk for cardiac at the age of 35, I want them to reduce that risk. And risks are measurable in healthcare. So this is where what we are saying is, how can I nudge them? How can I nudge that wellness part? One, of course, is a very old-fashioned way of saying, oh, Karen, or XYZ patient, high risk of cardiac, this thing, high risk of having a cardiac attack. And so, you need to get these tests done. But the other way to do it is to look at my behavioral pattern. So let's take a simple thing like for diabetes, you need to have somebody exercising and eating healthy. How do you achieve that goal? One is to just hammer home the message by saying, hey, eat healthy, walk more, eat healthy, walk more. It's going to fall on deaf ears. And the average life that somebody spends on an app is 2.5 months. After that, you move on to another app. Now, if you were to look at data, and that's why I keep emphasizing on data, because they give lots of insights which we don't look at, right? We do it in other industries, retail, finance, we really like dig home, but healthcare, we're still very nascent stage. So if you were to look and see behaviorally, what nudges Karen, or what nudges Rohit, or what nudges Rahul, right? Rahul loves to travel. Can I use that and nudge him on that? And Rohit loves to like eat food. He's a foodie. So can I kind of nudge him on the food part? So, and we have demonstrated this in major, with major governments and shown evidence that if you're able to nudge somebody based on their behavioral type, their persona, it's more long lasting. So for example, for diabetes, you might have somebody who goes the food route. He loves food. He's not going to exercise at all. So, okay, let's control that. Somebody loves to exercise, right? Okay, let's kind of push that person on that. So what motivates an individual's behavioral change? And that's where I think psychology also comes in. We need to understand that through data and be able to make very customized messages. Then the battle is won.
Yeah. Well said.
Very well said. I was just going to say, I need no nudging for food. So I think that way I'm very well profiling myself there. We're coming up on the hour, and this is clearly, as I always say, the beginnings of at least digging deeper into these important discussions. I think we've covered a huge and a wide variety of insights and understandings that we can take forward into other areas. And as I always say to our listeners, feel free to always write in or message and ask for any particular further deeper questions you'd like from our guests or from the Voices Project. Before we wind up, it's always important that I ask, particularly for Rahul and for Karen, after hearing this dialogue and summarizing your thoughts this way, what's your takeaway for our listeners? What would be your viewpoint that you could say, that's sort of the horizon for where we need to be heading to? I always try and say, give it to me in a sentence, but it's all right if you take a little bit longer than that. Rahul, would you like to go first?
I'll try in a sentence. If there are people listening in from the private sector, it is our generation that's going to make a difference to this planet and to its healthcare and other goals. If you're not stepping up to find these areas of collaboration and partnership, you're not giving back to the planet and to its communities what you were born here to do.
Karen, what would be your takeaways?
Yeah, I would repeat what I said earlier, probably in more than a line. I think convenience is the new currency. I think we really need to keep that in mind. And I love this fact that Rohit, you put up this topic of healthcare consumerism, because what it does is it makes the patients more informed about the cost, the quality of care. So it's like literally going shopping for your healthcare and making decisions in a very proactive way. deciding where and when they want to get their healthcare. And I think even from the employer's point of view, as we're all employed, I think it also affects health benefits plans, because earlier you would just be given a plan, but now I do find that patients and employees playing a very active role in what that plan should be. So this whole involvement and this change of the partnership is amazing, and I think it's a good change.
Thank you both so much. With that, we come to the close of this particular episode. Stay tuned for episode 4, that we're going to get into a further elaboration on how one wears one's own health. And we'll talk about what that means for the future. It's going to be quite exciting as well. Again, I'd love to thank you so much, Rahul and Kiran, for the time, taking that time out of your busy schedules. I think it means a lot to our listeners who come from a wide variety of academic institutions, governments, and folks who need to make some very important decisions. Thank you very much. And for anyone who wants to learn more about this, you can catch us on our RSS or Spotify feeds. You can always contact us through www.thevoicesprojectasia.org. I don't know why I always stumble over that one, but thanks all for listening, and look forward to taking this further. Thanks, everybody.
Thank you. Bye.
Thanks so much. Bye-bye.